MR cysternography. And recently we diagnosed a case, which was operated for, supracellular region somewhere, had a history of post-operative history of, CSF leak, intermittent CSF leak. Surgeons tried to, look for the site of leak, but in the operated site it was so difficult and they couldn't pick up. It was intermittent, small, and couldn't pick up. In spite of all means, by repeated CT and MR, couldn't pick up. What we did, the CT cystonogram was done. What happens with the CT cystonogram? You inject the dye, make the patient in prone position to stimulate the leak, and then you catch with the CT scan the dye coming out of the defect. But you know what happens? That in CT cystonogram, what the dye you inject remains in CSF space for maximum 1 to 2 hours. During that period of scanning with the CT scan, if the dye is appearing through the defect, then only you can pick up. CT is a radiation. You can't do CT scan again and again, to subject the patient to the repeated radiation. You can't take the CT scan once or twice, that too in a period of 1 to 2 hours. Because after that, the dye doesn't remain in the CSF state, it washes out. So our investigation of choice in those intermittent, difficult to diagnose CSF leak is intrathecal gadolinium enhanced cysternography, wherein the gadolinium is injected. It is very, very safe in the intrathecal space. Unlike the iodinated dyes we inject in the CT cysternography, those have the capacity to give severe reactions as well. So intrathecal gadolinium is safe, and the beauty is it remains in CSF space for almost 4 hours. Once you inject the gadolinium in the intrathecal space, it remains in the intrathecal space, subarachnoid space, for almost 24 hours. And since MRI is radiation free, you can subject the patient intermittently during that 24 hours to pick up the leak, to pick up the contrast or the dye appearing down the defect. We have seen in last patient in the 6th MRI, after almost say 14 hours, 5 MRIs went useless and the 6th one pick up where the leak is coming from. That's how in intermittent and most difficult to diagnose cases, the defects, our investigation of choice is gadolinium enhanced, intrathecal gadolinium enhanced MR cysternography. That is the most useful investigation in most difficult to diagnose and intermittent CSF leaks. That's how we pick up, all those CSF leaks. And in our series of CSF leaks, we have now more than 500 CSF leaks we have done at various places, not only from the nose and ventral skull base, from the otology, lateral skull base, and everywhere, wherein we found this sequence of investigation is our protocol, which helps us picking up the right diagnosis, the reason behind it, any high pressure, intermittent CSF leaks, and any complication which has arisen earlier because of the CSF leaks. So that has been our protocol.
Yeah, what is your experience about multiple sites of leak?
Yes, that is what I was coming intraoperatively. Once there is a spontaneous leak, we must look at the entire skull base at that point of time, expose the entire skull base so as not to miss any other multiple sites leaking. In spontaneous leak, you may pick up one side and be happy and go and close it like sealing a puncture. It cannot work. We need to see the entire skull base because the high pressure can lead to dehiscences and leaking from many sides. So like in this patient, we'll show you, we'll expose the entire ventral skull base right from the, the anterior frontal skull base to the ethmoidal roof, the sphenoidal roof completely, and look and have a close-up view from everywhere if there are any other, side which is leaking. So your point is valid, sir. We need to have a complete, skull-based tour, I would say, to look for any possible, multiple sites of leaking along with the site of leak.
Sir.
Sir, any other question before we move on? Sir, you were mentioning about the signs of the intracranial pressure. See this patient had a complete empty sella.
Yes, yes.
This is one of the patient would see how the dilated tortuous subarachnoid space around the optic nerve. These are
Yes.
classical signs of, high intracranial pressure. You see this indenting the optic nerve on the disc here, flattening of the globe. See the dilated tortuous nerve with a huge, intracranial space around the sheath. These are classical signs of, the high intracranial pressure. We must keep in mind and diagnose accordingly. See this one of the patient, the dilated Meckel's cave to the level you can imagine how the CSF pressure would be in this particular case. See this particular patient, the venous sinus, lateral sinus thrombosis on the other side. Whatever leak you seal, whatever diversion procedure you do, unless this cause of venous sinus thrombosis or this problem of sinus thrombosis is dealt with, it is difficult to treat the high pressure. So these are the, our sequence of, ordering the MRI as a difference now. In all CSF leak patients, we order MR cysternography with 3D FLAIR imaging, multiplanar, and MR venography. It is pure non-invasive investigation by all means. And then you get a complete information, not only about the site of the leak, but the other, possible contributory causes behind the leak. Everything can be picked up easily. Another thing on CT scan, if you see in high pressure, like sir mentioned, the high intracranial patient, you will see the calvarium. Look at the calvarium thickness on these patients because of the pulsatile, regular pulsatile pressure of the CSF leak on the calvarium lead to thinning of the bone. This is classical a sign you can pick up on CT scan on these patients where the CSF is, making pulsations. Another thing on CT scan, like you asked, the CT can pick up the continuity of the intracranial space with the extracranial, but it cannot describe you the content within it. CT cannot, give information about the soft tissue densities in detail. For soft tissue densities, we need to have MRI to characterize what exactly the content is. And see on MRI, you can find whether it is a pure meningocele, see the pure meningocele, or whether it is a meningo and cephalocele. That can only be picked up by MRI, not the CT scan. CT can give you limited information that some defect in the bone, which in continuity could be CSF. There could be only, sometimes what happens, I'll give an example. There could only be bony discontinuity and nothing else. So CT can never give you, a complete information about everything. Like for example, this patient, this is not about CSF. We are talking about the CT versus MRI. This patient had a, defect in the bone on CT scan, look like some continuity in the there from the intracranial to extracranial space. On MRI, it revealed only that the bone was decent and the intracranial space was absolutely normal and segregated. On this CT scan on both sides, the tumor was there, but we were not going intracranial at all, just bone erosion. But the dura was intact. Look at the dura, completely intact. Not even enhancement, only the bone was eroded. In the other situation, you see the same thing. The bone was eroded on CT scan, and what you find in MRI was a huge tumor with intracranial edema as well. And yet, the CT scan is showing just bone erosion because CT cannot differentiate in the soft tissue densities, intracranial and extracranial, what it is. And to characterize those, you need to have a good MRI to pick up the, difference in the soft tissue opacities, what exactly they are. So this is something we must know, that the MRI is the investigation of choice beside the CT scan in those situations. And we need to have a complete, we should order, the difficulty comes sometimes patient brings up a CT or MRI in pictures with you, with the printouts in hand, with the diagnosis of CSF leak, and it looks so bad to order a MRI, a proper MRI again to the patient as well, that doctor, I have already got the MRI, and why are you unnecessarily ordering the investigation? Maybe you are trying to mint money out of this. This is not the reality. We need to tell our patient that we need complete information to prevent post-operative surprises. Otherwise, what happens? You don't get the investigation now, and post-operative you'll find there was venous sinus stenosis, there was high pressure, this was this, that, there was tumor inside, and we miss that because of the inadequate information beforehand. So it should be a protocol, what we believe, to order a proper all sequences MRI before tackling the CSF leak cases, because all cases are never straightforward. There are some complex situations. It is better to rule out them before rather than getting post-operative surprises. Any questions, sir?
Yeah, excellent. So that means, I mean, even if you get a straightforward only single defect in the, I mean, in CT scan, and the site of leak and the CSF examination done routinely, as most of the center do not have all the facility. So if the leak is a CSF, sugar estimation and other things, and clinical examination, and if there is a single defect on CT scan, still, and clinically no evidence, may be post-traumatic or delayed, so still you will go for all sequences of MRI. You are right that rarely, yes, you can have those sinus thrombosis, because if you don't treat the cause, if there is a raised ICP, you have to repair this. And if post-operatively the raised ICP is not controlled, then you have to address the raised ICP also in form of either medication or a shunt or whatever. So you are absolutely right, but as you said that most patient will say, डॉक्टर साहब ये तो हमने करा लिया, अब फिर दोबारा क्यों करा रहे हो? So
Yes.
still you persist, means even if you are fairly sure single defect on CT scan and the site corresponding and everything, you like to go for all sequences?
Sir, in traumatic leaks, we can get away without getting done all this. But in spontaneous, we must get all sequences done, because spontaneous is something which can give you surprises. A traumatic leak with a history of clear-cut trauma, history of CSF leak immediately after trauma, from the side of the leak, you see a defect on CT scan from that particular area. That is good enough to diagnose that. You don't need all these sequences of MRI. But in spontaneous, there could be a lot of hidden things which can give you surprise later. Also, spontaneous leak should be worked up. Traumatic, you can leave upon the CT scan based on the corroborative, history and the clinical findings. So spontaneous, if you ask me personally, yes, it is must. Otherwise, you may get surprises. Traumatic, you can get away with the CT scan only.
Yes, yes, please.
Traumatic is always straightforward. On the side
Yeah,
of the leak, you find a defect in the bone, and the CSF is active, leaking from that place. You don't need anything more to further evaluate. But yes, spontaneous is a mystery. Many a times it's a mystery, and you have to have complete information behind what is happening behind, which has given rise to the CSF leak in a person who had no history of trauma. We need to know. Otherwise, sometimes the patient feels cheated post-operatively when you ask that you have this problem also. Now you need another surgery for the shunt. Now you have this problem diagnosed. You need another stenting of the venous sinus, and he will ultimately lose the faith. You have to have a complete, one-to-one discussion with the patient regarding the entire problem after all these sequences, that this is the situation, you have high pressure, and you may have to undergo post-operatively. If the pressure remains elevated, to prevent recurrence of the leak, we may have to do another procedure that has to be, better it is told the patient beforehand.
so one of the delegate is asking about the, I mean, which investigation. So to summarize what Professor Jain has already said, that a single defect in the CT scan corresponding to the site, and especially in the traumatic leak, you may not go for sequences of MRI. But if you have multiple defects, even if it is a traumatic leak, and if there are multiple defects, fractures, defects in the CT scan, then you don't know from where it is coming. In those cases also, you need to have MR cysternography. If there's an intermittent leak, he has very beautifully said that in, I mean, intrathecal enhanced MRI is better than CT cystoscopy because you can detect it much later. The dye stays for very long period compared to the intrathecal CT scan.
And
Okay.
more than that, sir, and more than that, MRI is non-radiation. There is no radiation. You can
Yeah.
subject the patient during that 24 hours to the MRI again and again to pick up any leak which is intermittent at that particular time may be revealed. CT you can't repeat again and again because it is radiation, and that the dye which is iodinated contrast which is injected in CT scan, CT cystogram doesn't stay for longer period. It
Yes.
has the propensity to give reactions also many a times.
Yeah, so I think, and you have to address the raise ICP if it is there. So close the defect and be careful, especially in a spontaneous rhinorrhea about the raise ICP, because around 50% of these spontaneous rhinorrhea have some kind of raise ICP. So we like to see your masterly surgery, sir, please.
Yes, sir. We are all set to begin.
Satish,
Yes, yes, boss.
does this patient had meningitis also or not?
Yes.
Twice. Twice.
Twice. Okay.
Yes,
So this
yes.
time, this time not no meningitis.
This patient is from Gujarat. He presented to neurology department 6 months back with meningitis.
You already told. I know that. I just want.
It was treated on the line of meningitis, and on those times, with CT scan and MRI, they couldn't pick up any CSF leak because it was a small and intermittent and couldn't be picked up.
But
then
this time no active meningitis. This time there is no active meningitis now.
No active meningitis. So first time she was treated for almost 1.5 months with intravenous antibiotics. Then she was discharged, she was doing well, had intermittent leak. Again couldn't pick up. 3 months back, again she developed meningitis. The same story.
When you operate, that time, how do you rule out that there is no active meningitis? It's only clinical, or do you do CSF also?
No. All three means we always take into consideration to pick up any active meningitis thereon. Number one, a contrast MRI, which will tell you the enhancement in the meninges. Number one. Number two, on high clinical suspicion, you can do a lumbar puncture and do the cytology and the cell count. And number three, in patient develop fever or any other symptom, we do as a corroborative, we get procalcitonin done also. So, but MRI is a preferred initial method, contrast MRI. In case you have any doubt, any suspicion of a meningitis, the contrast MRI can pick up the enhancement in the meninges, which can give you a fairly good diagnosis of ongoing meningitis.
But I think if there was a meningitis, the enhancement will continue for a few weeks, even if the meningitis is resolved clinically. No,
yes.
Dr. Tigar, what you say?
So that was the diagnosis part. Now, to take a call for the surgery, whether the meningitis is resolved or not, then is it different. Then your clinical findings, your CSF findings, also important whether the meningitis is resolved or not. Then the role of radiology is less important.
Okay.
You may have changes in the meningitis. Kuch mix kiya, I guess.
What nasal deconcentration you are using and what concentration?
Yeah. Yes, sir. So I hope you are getting the endoscopic picture.
Good
How
picture.
the picture is, sir? How's the picture?
Yes, excellent, excellent as always.
So I am in the right nasal cavity with my 0-degree endoscope. And yesterday we talked about the anatomy. I couldn't show any anatomy on the given period, but for everybody in the right nasal cavity, let me take you to the endoscopic tour. This is the medially, this is the nasal septum.